Hello, and welcome to today's webinar, Safety Planning for Women Experiencing Homelessness. I'm Caroline Gumpenberger, and I will be the moderator for the webinar, presented by the National Healthcare for the Homeless Council as part of our spring virtual training series, Her Health, Her Housing, with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the last 10 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenter for written responses after the webinar. If you are having technical issues, you may also call the Council's office at area code 615-226-2292. This session is accredited for 1 continuing medical education credit hour through Vanderbilt University Medical Center. If you would like to claim credit, please copy the information located in the CME Information Notes pod at the end of this session and follow the instructions. The claim code will only be available during this session and will appear in the last 20 minutes of the presentation. In order to receive credit, CMEs must be claimed within 3 days of the end of this presentation. Our presenter today is Cindy Manginelli, 10 Care Shelter Enrollment Project Coordinator at the National Healthcare for the Homeless Council. Thank you, and now I'll pass it to Cindy.
Thank you, Caroline. So you can see here our learning objectives for today. We're going to be talking about sort of the who, what, when, where, and how of forming a good safety plan. And you can see there exactly how we're going to move forward. So let's start off with talking about why prioritize a safety plan. Several years ago, I was working as a children's counselor in a domestic violence shelter, and we had about 50 people that could stay at our shelter, and we usually had about 25 of those were children. For about a 3-month period, we had 5 5-year-old little boys, and it was really rare to have a group of children who were all the same age, and so it was super cool. It was heartbreaking in some ways. Because of all the stories and all the things they had come through. But it was also really cool, the different ways that we could, the different activities that we could do and the different stories and how we could kind of blend all of that together. So we had these little boys, and of course each one was very different. But one little boy was Jacob. And Jacob was someone who'd been in our shelter many times. He was 5 years old, and he'd been in shelter 7 times since the time that he was born. And on one of his very first visits to shelter, he had received a stroller from one of our case managers when he was a baby. And he loved the stroller. His mother had built different compartments on it, and she used it to haul all of her belongings and to haul Jacob. And even though Jacob was 5, he still pretty much lived in that stroller. And if his mom wasn't there to push him around, he would actually push the stroller to wherever he was going to be, and he would sit in it and function in it like a wheelchair. And so we all just adjusted to that. That was just Jacob. But one day I was driving to shelter, and I was about a mile from work when I saw Jacob's stroller upside down on the road. And so I knew even before I got there that something had happened. So I pulled into the shelter, and I learned that last night, the night before, around dinner, Jacob's mom had come home, and she was just completely drunk and raging and just really out of control. And in all of that, she had threatened a case manager, and case manager had to cause her to leave, and it was a big ordeal. And so in her anger and in her frustration, she had packed up all of her belongings and left. And about 2 hours later, Jacob was found under someone's bed, under the bed of another resident. And she'd left him. She'd forgotten about him. And so the Department of Children's Services was called, and Jacob woke up to strangers who took him to live somewhere else. And so when I gathered with our little group of boys that morning, they were devastated. They were so sad. You can imagine just that deep sadness of worry about their friends. And so I gathered them together, and we sat and we talked for a little bit, but no one really knew what to say, including me. And after a few minutes, one of the little boys, Sean, who was very much the leader of the group, said, "Guys, it's going to be okay. Don't familiar with Sean's magic special stone. It was a little clear river stone that he had received at Vacation Bible School that had a little cross on it. And Jacob was absolutely certain that this stone gave him magic powers and that it allowed him to be victorious and to overcome in any situation. And we had all heard the stories of the powers and the victories won by Sean's special magic stone. And so when he said that he'd given that to Jacob and that Jacob had it, there was just this sigh of relief. It's all going to be okay. It's all right. He's got the special stone. And, I just went with it. I just totally said, okay, he's got the stone. And we were all relieved. And we talked about it more in days to come, but for that moment, we were all just, all right, it's going to be okay. And we all went outside and we had popsicles, which was Jacob's favorite thing to do, with a little feeling that he was going to be all right. Probably all of us have been in situations with clients where we really wish we had a special magic stone, where we wish we had something that we could give to that client that would allow us to feel very confident that they're going to be okay, and some sort of guarantee of their safety. And as it turns out, we don't, but a safety plan is probably the closest we can come to having that magic stone. A safety plan allows us to give our clients something of a safety net, something that they can fall back on. And it allows us a little bit of peace of mind, and agency-wide a little bit of peace of mind to know that it's going to be okay. So let's talk about, that's sort of the idea of why we prioritize a safety plan and why that's a good idea. Let's talk now more specifically about what that's actually going to entail. So when we think about a safety plan, we're talking about responding versus reacting. We're talking about let's think through, let's be purposeful, let's think through why we're doing what we're doing. So often women experiencing homelessness are making a series of knee-jerk reactions. What do we do now? What do we do now? Another crisis presents itself and I have to decide, what am I going to do? And there's this constant reacting in crisis. And so what a safety plan allows is it allows us to respond. Let's create a safe place. Let's create some time where we're all going to get together and we're going to think through what you have coming up and what you can do to stay safe in those situations. Let's plan a response. And that's really the gift of the safety plan. Sometimes it's not the plan itself that is as helpful as the fact that you created a space where your clients can really think through, okay, what are my circumstances and what can I do to stay safe? And can put some intentionality and some purposefulness behind the next few days, maybe the next few hours, maybe the next few months, but it creates that place. It also allows your clients a real opportunity to build some coping skills, to be intentional about building coping skills. All right, when you're in these situations, what can you do? What helps you to feel grounded? What can you do to feel successful? What can you do to feel safe? Let's plan out some coping skills as opposed to just trying to numb the pain or numb the fear in those scary moments. And so, again, a safety plan creates space and creates time where you can decide how you're going to cope as much as possible. And so all of those things, of course, really empower the consumer. They allow the consumer time to feel like, well, you know what, I'm being intentional. I'm making decisions here. I know what I'm going to do. And all of that creates a sense of purpose, a sense of power, a sense of control. So again, that's where the process of the plan is very valuable, regardless of it in the plan itself. Just that time and space are very valuable. And then it provides a safety net. What you're really hoping to create is an emergency plan, a go-to plan, and a safety plan can really be that. And for many of your clients, a safety plan can be life or death. It can mean the difference between life or death. So, what a safety plan is not. A safety plan is not an evaluation of lifestyle choices. A safety plan is not the time where you're going to sit down and say, you should do this, you should not do that. A safety plan is more, we're going to look at your circumstances, we're going to look at what you have going on, and figure out how can we keep you safe in light of those things. How can we keep you safe while you move forward? It's not a, wow, that's a terrible idea. I can't believe you're going to do that. It's not any of those things. It's really just looking at reality. If this is what you're going to do, How can we keep you safe in that? Now, there may be other times when you go through and have those conversations. In fact, maybe there should be. But a safety plan is not that. A safety plan is not going to be productive if your clients feel like I've got to give information that will keep this safety planner from getting angry, that will keep this safety planner from disengaging. It needs to be a time where the client feels I can be completely honest. It is not a wish list. So a safety plan is not the time when you're going to say, well, if your mom wasn't so terrible and if she took good care of you, we wouldn't be having this conversation, right? It doesn't need to be any of that. It doesn't need to be any of the focusing on the negative, focusing on what you don't have. If you do that, then the client can leave a safety planning session feeling very negative, feeling very defeated, perhaps even feeling more frustrated because you focused on what they do not have. The safety plan should really be a time when you focus on what you do have. Let's not make this a wish list. Let's move forward based on the assets we have. A safety plan is not corrective. Again, this is not a time when we're saying, well, if you would do this, this would be better. Well, that's why you shouldn't do that. No, a safety plan is not going to be like that. A safety plan, again, is looking at your current circumstances. And then really importantly, a safety plan is not a guarantee of safety. And I would think that would be obvious, but we can use safety planning time to try to comfort our clients and to try to sometimes make promises we can't keep. We're going to talk more about that later. But a safety plan is not a guarantee. So you can't say to your client, okay, we've gone through all these scenarios. Now we know everything's going to be okay. Well, now you don't have to worry about that anymore because we've spent this time talking about your safety. Of course, we all know you could safety plan for an hour and walk out the door and get hit by a car. So a safety plan is not a guarantee, and you want to make sure that your clients know that and they don't feel a false sense of safety created by the plan. So now let's look for a minute at who should assist the client in completing a safety plan. This is something that you may not give a whole lot of thought to, but it's actually really important. So first of all, ideally, and all of this is ideally, some of this you may not be able to do, and that's okay. Any talk about a client's safety is going to be profitable talk, and it's going to be something good to engage in. But this is what we would be looking at ideally. Ideally, when we get to a safety plan in your system, in your process, we would be looking at someone who is familiar with your client's story. So often, as you know, in so many programs and agencies, a client may have to tell her story 8, 9, 10 times over and over, sometimes in the same day, and write it out and write out details. So we don't want the safety plan process to be something that's oppressive or overwhelming or that causes your client to get kind of bogged down again in the details of her story. Ideally, the person who's creating the safety plan is already familiar with her story, already knows what's going on there. Okay, we're going to pause for just a second because we're having a lot of people who are having trouble hearing. And we're going to disconnect, and I'm going to call back in and see if we can get a better connection. So let's pause for just a second, and I'm going to try to call back in and see if we can correct some of the problem with people not being able to hear.
Hi everyone, this is Caroline again. As Cindy said, we're having a little bit of a technical issue with the sound, so we're going to have Cindy disconnect and call back in. If you would bear with us for just a moment, we'll be right back with you.
All right, so we're going to try and get back engaged here and see if you can hear me a little better. Caroline, does that sound better to you?
Yes, it sounds good on our end. Hopefully some of our attendees will let us know if they can hear okay, and we'll try to keep an eye on it as we go forward.
All right, that sounds good.
Wait,
so
wait
we're going to jump.
The audio. Wait, just 1 second. The audio is still muted on the attendees line. Let me turn that back on, and then I'll give you all a cue in the presenter chat. Okay.
Okay, we have Cindy reconnected, and hopefully that should help our issue a little bit. So if everyone could please let me know if they can hear okay as we move forward. Cindy, you could go ahead and get started.
Great, thank you so much. So hopefully this will be a little better. So we're going to jump back in here as we're talking about exactly who prepares the safety plan with the client. So as we said, this is going to need to be someone who's familiar with her story, and ideally this is someone, and this may be really hard to do, who does not determine what benefits or services the client receives. So of course, what can happen here is that if I feel like I've got to tell a very specific kind of story in order to receive services, then I'm going to tell that story to everyone I talk to in order to receive services. So maybe I realize that in order to receive services through your agency, I have to say I don't smoke, I have to say I have 2 children, and I have to say that I live alone. When in reality, I smoke 3 packs a day, and I've got 5 children, and I'm living with my boyfriend. So if I make a safety plan that is not based on reality, that's completely based on a misrepresentation of what's going on with me, then obviously it's not very profitable as a plan. So if you can do safety planning with someone who does not determine what services are received, then the client may feel like this is a space where she can be more honest and where she can tell her story more accurately. Ideally, this would be someone who sees the client regularly. And that way the client doesn't have to retell her story every time, but someone who's kind of following the ongoing narrative of the client and can adjust the safety plan, kind of tweak it from time to time, and not someone who's going to have to go through this whole process every time the client comes in. Very important that this person has a strong knowledge of community resources. There's no value in a referral that's outdated or that's not relevant. And so if you have someone doing the safety planning who really has no idea what community resources actually offer, not what they say they offer, but what they actually offer, then the whole safety plan may be built on resources that aren't actually available. This person would also understand the client's emotional and physical needs. If this client has specific fears or specific medical conditions or transportation limitations or anything like that, it would be really important for the person doing the safety plan to know that. If you don't know the client well, you may make referrals that are completely irrelevant to them. And then lastly, it's important that this be someone who is trusted. So when you think about, I've worked in programs where if a client, becomes really agitated and we have to ask that client to leave, they've got to be exited in a crisis, that the same person who's basically kicking the person out of shelter is also the same person doing the safety plan. And obviously that breakdown in relationship prevents the plan from being valid at all. So it needs to be someone that the client feels safe with, that the client feels trusted talking to. So the plan must be developed and led by the client. And this is one of the hardest things to do in safety planning, but one of the most important. The client has to determine her needs. She has to determine what is or is not safe, and she has to determine her priorities. Very, very important. I can't look at a client and tell her what is safe for her. I have worked with many clients who describe situations, in their safety plan that I just thought, wow, that's not safe at all. I would never want to do that. I would never want to try to go there as a safe place. And yet, for the client, it was absolutely safe. It was ideal. So you have to let the client determine what is safe. There are really common sense things that many of us would do when we feel like we're in a dangerous situation, like call the police, that our clients may feel really unsafe doing. So it's important to continually turn back to the client. What do you feel would be safe? What do you feel would be best?
And then are there additional players to consider as we consider the who of safety planning? If your client has a parole or a probation officer, then obviously they've probably safety planned with that person, and that plan must be taken into consideration. If any sort of law enforcement involvement, if they have a felony or if they're sex offenders, are there places that they're not allowed to go to? Are there meetings that they have to make in order to avoid future incarceration? That's going to be really important to take into consideration when you make a safety plan. Anyone who has an active case with the Department of Children's Services has also probably made a safety plan with DCS, and so it would be really important to incorporate that as well, because if their main priority is to keep their children and to not have negative interactions with DCS, then the DCS safety plan is going to be really, really important. So what does a solid safety plan include? What are the aspects that we really want to include in this safety plan? Let's look realistically first at your program. What kind of plan can we develop? And so there's the ideal, and then there's what we can really do. And that's what's going to be really important. So if you're really thinking about we want to include safety planning in our system, in our process, then it's important to talk to the people who are going to be doing that safety plan and to think realistically about what's available to you. How much time do you really have? You may decide we want to do a super thorough five-page safety plan. But if you really know, all we've really got is 30 seconds or all we've really got is 3 minutes, then you need to consider what is most important for us to include. How much time do you really have? And then how much time and energy does the client realistically have by the time they get to this process? If you've got a 2-hour intake process and your client has talked to 12 people and filled out 22 different pieces of paper, then what do they really have left by the time they get to the safety plan? So that may inform where you put the safety plan in your intake process, but it should certainly inform what you expect to accomplish during that safety planning. And then what is the client's competency level? What are they really able to do at that point? What are they really able to think through? You don't want this to be stressful. You don't want this to be another, checklist full of questions that we've got to get through. What is the client's competency level? And realistically, what can they really get through? When will someone from your agency next see the client? That's an important question. There's no reason, probably, to go through a 2-hour safety plan if you're going to see her tomorrow, right? If you know I'm going to see her next week, we're going to see her every week for the next, 3 years. Take that into consideration. Now, there's no guarantee, obviously, of when we'll see our clients again, but that can be an important piece that can save you and your clients some time and energy. And then most importantly, what is the level of lethality or the real chance of significant harm? If you have a client that you're meeting to safety plan with and you know they're going to walk right down the hall and sleep in your shelter that night and they're not going to go anywhere until next week, then that should inform the amount of time you spend safety planning. However, if you know that your client is going to walk out of your office and walk into a very dangerous situation and that you may never see her again, there's no follow-up, then that too should inform your safety plan. So what is the real level of lethality? And we're going to talk about gauging lethality in a few minutes. Some more questions to consider. What is most important to you, and by you I mean the client, what is most important to the client right now? That's where your safety plan needs to focus. Her most important thing may be, I just want to stay alive. I am scared to death. Or her most important thing may be, I really want to keep my children, or I really want to get a job, or I just have to quit smoking. It could be anything. That needs to be the central focus of your safety plan. That needs to be where you spend the bulk of your time, not, again, on what you think should be most important. There's no value in completing a safety plan that a client has no intention of ever following. There are many, many steps in your process, I'm sure, where you have to fill out that paperwork regardless of what your clients want. It's important for outcomes. It's important for donors. This probably isn't. This is a chunk of time that if it's not good for the client, why bother really? So focus on what's important to her. And then use a strengths-based approach. What is working well? What's working well for this client? What does she have going for her? Where has she typically felt safe? Where has she run to for safety in the past? Who has she run to? find those strengths and capitalize on that in the safety plan. All of this is really going to speak to the fact that a cookie cutter safety plan where you just have a printout that you give to every client may really not be very useful. But if you can help a client to intentionally think back, okay, well, you've been through some hard times. You've had some significant difficulties. What'd you do? Where'd you go? Who'd you talk to? What worked well? And really focusing on making a plan that capitalizes on the client's past successes. And then what is dangerous for you right now? Where do you go and feel the most afraid and the most threatened? Who do you hang out with that makes you really feel scared inside, that feels really unpredictable? And what can we do to kind of plan around that? The big questions here are where and who. Where do you go to feel safe? Where do you go that feels really dangerous? Who feels really safe to you? Who do you trust? And who do you feel like is a real threat? Keeping in mind, again, that you probably cannot say, well, then never go to the dangerous places and never hang around the dangerous people. Your client may have made the decision, this place is really dangerous for me, but I'm absolutely going to go there. I don't trust this person at all, but I'm absolutely going to spend time with them. So in light of that, again, we're looking at your current circumstances. What can we do to keep you safe in all the places and people that you're going to encounter? So when we think about a safety plan, we're not just talking about physical safety. Physical safety is a big part of that, but mental and emotional safety is important as well. I have sat with clients and really worked through some physical harm, some potential physical harm coming up in their future. I've talked to clients who absolutely decided to go back to an abusive partner because they were physically safe there. And they felt physically more safe in a home with an emotional abuser than they did under a bridge or living in their storage unit. But once they got there, they committed suicide. It was a physically safe place for them, but it was emotionally life-threatening. Eventually, physical safety and mental emotional safety overlap, and sometimes that can happen quickly, and sometimes that's long-term. So just allowing your client to think through those possibilities and not just focusing on physical safety. But when we think about physical safety, big things that we want to consider are medications. That's going to be huge. Does your client just have a bunch of pill bottles, or does she know what medications she takes, how often, and where to get those, and what providers prescribe them? That's all important to know and to have documented somewhere other than just on the literal pill bottle. Allergies and health conditions, is there some way that, to a bracelet or a necklace, is there some way to have those on her phone? Is there somewhere to put those on her physically? Is that important based on where she's going? Are those documented somewhere? And then any substances that she's using. And this one obviously is a little, they'll have to determine whether they feel good about this or not. But that can be life-saving information. I had a client who, every time she used a substance, she wrote on her hand what she was injecting and how much. Because if someone found her in an alley or someone found her on the street, she wanted EMT to know exactly what she was taking and what to do. So that may be a little extreme, but it's that kind of idea. Does anyone know what you're using and how much of, and then in relation to that, your physical health conditions? And then, of course, ideally the name of an emergency contact, even if that is an agency rather than, a family member or friend. Ideally, it would be a family member or friend. In like mind, what do we think about with mental and emotional safety? And this is where medications, mental health conditions, and providers can be so important. A lot of our clients, most of the danger that they face is because of this cycle of I get arrested or I get, or I get institutionalized, and I'm given a diagnosis and I'm given medication, but then when I leave the hospital, I'm not sure of my diagnosis, I'm not sure of my medication, maybe it's stolen, maybe I just decide not to take it, and then 6 months later, I'm again institutionalized and given a new diagnosis and a new medication, sometimes when the previous medication is still in my system. And so literally just this cycle of insanity of just such a vast combination of mental health conditions and medications. So having all that documented so that if I have a real breakdown and I get arrested and I'm put in the hospital, someone can see what my history is or know who to call to get it.
And then again, coping mechanisms. What has worked in the past? What can I do in a scary place when I'm feeling very frightened, very threatened? What can I do to feel grounded? What can I do to cope? And is there a way to plan for that? So just some common sense things that may seem, really clear that a lot of people don't think about. One is that there's safety in numbers. And we say that, and that seems obvious, but the reality is that a lot of women, when they're afraid, withdraw. And so, I personally feel a lot safer in a dark closet than I do sitting in a hospital waiting room. I like the closeness, I like the dark, that makes me feel safe. But the reality is that if someone is looking for me to hurt me, if I'm in danger, the safest place for me to be is a place where there are lots of people and where it's well lit. And so to kind of fight that tendency to withdraw, unless your client just really does feel like, in my situation, this is safer. And then a lot of people use a safety password, and the safety password idea can be really helpful. It's not really helpful at all unless you follow that up with action steps. So what I mean by that is telling someone in my support system, someone that I know well, hey, if I call you and I say this word or this phrase, that means I'm in trouble. That means I need you to fill in the blank there. So if I call you and say, hey, I'd like to order a pepperoni pizza, that's my way of saying to you, I'm in trouble. I need you to use the app you have and track down my phone. Or I need you to come to the house and get me. Or I need you to meet me at this McDonald's. Whatever that looks like, developing that safety word. A lot of people will just use a text. If I text the letter X to you, that means I need you to call me and I need you to intervene in my situation. So that can be really helpful for a lot of people if they have that support system to rely on. Avoiding confined places. So it's going to be much better if I'm with someone that I feel is not safe or I feel could potentially become unsafe to avoid little tiny places. I want to look for places where I've got room to run, where I've got room to duck, honestly, where there are lots of exits, where I can't be trapped. In that same vein, avoiding kitchens and bathrooms. If I get hit in the kitchen, anywhere I land, it's going to hurt. And there are so many potential weapons in the kitchen and in the bathroom. So if I see that someone's escalating and I feel like the situation's becoming unsafe, I want to look for a place with lots of exits, with lots of rooms, and with lots of room, and potentially where everything is soft if I land somewhere. And then to really talk about watching the behavior of those around you. Perhaps you've been with this person for a while, you've seen them get abusive. What are the actions kind of leading up to that? Or let's talk about your mental health. Do you know some signs that you're coming towards a crisis, that things are getting out of hand? So talking about triggers, talking about looking for cues in myself and in others that things may get dangerous, and then what do I do if that happens? And then use your voice. We all know that most children and most women who are abducted typically don't scream. We live in a society where, we really teach ourselves and our children to be quiet and not to draw attention to ourselves. So I would take children that I'm working with and we would go outside and we would practice screaming and getting used to that sound and making that sound. So use your voice and talk to your clients about that. And then, do you call the police or do you not? That's something to think through. A lot of women will automatically think I would never call the police, maybe because of fear of someone in power, fear of a man in power, fear of someone with a weapon. All of that can be valid. It can also be invalid. So at least talking through that. Would it be a good idea to call the police? If they have an outstanding warrant, something like that, then it may really not be. But there may be fears there that we can talk through and determine, is that really a valid fear, or should this really be a part of my safety plan, is calling the police? And I would say along that same vein that when we think about calling anyone, calling someone in their support system, when we think about those safe people, especially with youth, I will very often work with youth and say, is there anyone you can call? And they'll say, no, there's no one I can call. I'm totally alone. My parents hate me. They never want to talk to me again. But maybe because they need a signature or they have to have a guardian, at some point we will reach out to the parents and find that that's really not the case. And that in reality their parents would be really happy to get a call if there was an emergency. So sometimes it may be wise, just a little bit of pushback there. Are you sure you have no one we can call? Is it worth a try? Would maybe be the question I would ask there. Is it worth trying to you, or is that just too much of a minefield to even think about navigating? So really significant risk factors. So these are people that are really at risk. And first of all, it's going to be those who are solitary, those who really are completely alone. If you never have anyone expecting you anywhere, right? I could disappear off the face of the world right now and no one would know it. That person is really at risk, because if something bad happens to them, there's no one looking for them. There's really no one to call. So anyone that you're working with that's in that situation, that should be a big red flag. We really need to think through a plan. Anyone with a serious medical or mental health condition, and we just talked about that some, but epilepsy, someone who can become catatonic, or who can just lose consciousness, or anything like that, where they may no longer be able to advocate for themselves. That's someone who's in a real risky place and needs to think through the risks associated with that. Someone who's nonverbal. Now, we all probably have worked with clients who literally just don't talk, especially maybe children, and that, of course, places them at such significant risk. But we also may have clients who just don't talk, who just are completely withdrawn and literally almost never talk to anyone. Predators will really prey on people like that. That's what they're looking for. They're looking for people who won't scream, who won't complain, who won't call the police. And so anyone who just doesn't talk to anyone is at significant risk. Someone with an intellectual delay, if they have problems functioning with executive functioning kinds of things, a hard time making decisions, anyone with a really low IQ, of course, that's going to put them at significant risk, because even just making decisions will be difficult and make them more vulnerable. Same thing with someone who's just really naive. I've had clients come out of domestic violence situations where they've never handled money, they've never paid a bill, they've never owned a phone, they've never driven a car, where they were just really controlled. And so that makes them very vulnerable, because they don't know how to navigate all those systems. I've had women who walked into shelter, and after being there for half an hour, they had literally given away every dollar they had, because they were just really naive and really kind of gullible. And so resources just went right through their fingers. So people with that weakness are going to be really, again, a real risk factor. So, of course, everyone living in a domestic violence situation is at risk, and that can get really scary really fast. But these are different actions that we consider high lethality actions. So if someone does one of these things to another human being, they've really crossed a boundary where you can really assume that they would do anything. And that is specifically someone who chokes another human being and someone who burns another human being. If you've been choked or you've been burned, you're with someone who is very, very dangerous. Those are sort of on the far end of the lethality spectrum, and that's very dangerous. And of course, if they have a weapon, they're in the home, then you're at greater risk. Or if they have used anything as a weapon against you, then you're at greater risk. The use of a weapon there is a huge red flag. Really need to do some safety planning around that. Anyone who's hopeless, you talk to someone and she says, I don't think this is ever going to get better. I've lost all hope. I have no idea what to do. Everything I try fails. There's no point in trying anymore. Those are things that aren't overtly suicidal statements, and yet would cause you to see that the person is hopeless. And so someone who's hopeless, of course, is at a far greater risk for committing suicide, but someone who's hopeless is also at a far greater risk for taking unnecessary risks, for not giving any thought to their safety if they already feel hopeless. People who are younger are at much greater risk, as are the elderly. And anyone who has a history of gang involvement or prostitution. If you have someone you're working with and there are a group of people who believe that they own that woman. Most gangs, once you enter a gang, you are never allowed to leave. And so they will keep looking for you, or they will certainly try to take ownership of you if they ever see you again. And many pimps are the same way. So if you're working with a woman, and there's a group of people out there who believe she's ours, then she's at far greater risk than just the average person trying to avoid dangerous situations while navigating homelessness and crisis and all the things we're talking about. Let's talk briefly about suicide and self-harm contracts. This is not a big thing we're going to cover here. This is not a webinar designed to address issues around suicidal ideation. But I do want to talk about this because a lot of people will incorporate into their safety plan a suicide or self-harm contract, which if you're not familiar with that is basically a piece of paper that says, I promise I won't kill myself, and then the person signs it. It's more in-depth than that, but that's the gist of it. Some people will use this then and then feel very confident now the person won't commit suicide. And that is a very dangerous use of these forms. It absolutely cannot be that a suicide self-harm contract is your primary way of intervention with someone who's potentially suicidal. You can use this form as assessment. So in other words, I hand my client the form and I see what she does with it. Does she just immediately sign it? Does she say, oh yeah, this is no issue at all? Or is she hesitant? Does she ask why? Does she seem to kind of wiggle around that? That would be indication that I need to take a next step. But you would certainly never want to give someone a suicide and self-harm contract and then say, okay, well that's done, so we don't need to ever talk about that again. No, again, an assessment only. So we've talked about who's going to do this safety plan. We've talked about all the different components that it could potentially include. Now, what do we do with all of this information that we've collected? What most people will do, I think, is just hand it to the woman. Okay, we've talked about all this. We've written it all down. Now here it is. We really need to think through this. Is it safe for this woman to be walking around with a list of every medication, every provider, and every safe person that she knows in the world? Because if someone, a violent partner or someone who just wants to manipulate her gets a hold of that information, they have everything they need to manipulate her. They know what's important to her. They know what medication she takes. You see what I mean? And very often, there's our logo right at the top, right? So now, not only do I know everything that's important to her and everyone she trusts, but I know the one place that she went to for safety. So we really have to think through, and of course it's up for the client to decide that, but is it really safe for you to walk around with this information? What information do you absolutely need to walk around with? We talked about mental health conditions, physical health conditions, and what do you just need to really kind of store in your head, or what do you need to put this in a safe place? But be intentional about what are you going to do with this really important document you've created, and what would be most helpful to her. So if all else fails, we've talked about a whole lot here, and you just think, wow, we cannot do that. We cannot go through all that. What can we do that's the most basic, the most simplistic form that could still be helpful? And that's what I call sort of a popcorn safety plan, just a 30-second, what can we do where we at least broach this subject. And one thing that we can do is we can look at our client and say, okay, we've talked about this, your next appointment. We've talked about, whatever your program looks like. This is what you're going to do now. Here are the action steps we discussed. You're going to do this, you're going to do this, and if things get really scary, if things get really dangerous, you're going to do this. So just a 30-second, here are your action steps, and here's what you're going to do in its most basic form if everything else falls apart. So you're going to go get your driver's license, you're going to find your birth certificate, you're going to come back here in 2 weeks, and then if something terrible happens, you're going to reach out to your mom. If something terrible happens, you're going to go to the hospital emergency room and just sit in the waiting room, right? Is that a plan? Great, let's do that. Or even better, okay, what are your action steps? What are you going to do from here? Yes, you're going to do that, you're going to do that. Oh, remember, you're going to do this, yes. And then what are you going to do if you get in a really scary situation? Boom, 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 I'm going to do this, great. If all else fails, it's usually pretty simple to do that. And something to consider is, how many people in your program could do that? Maybe there are 4 people that she will see in the course of her time in your agency who can do that. Maybe someone every day while she's in your shelter. Maybe the doctor and the nurse and the receptionist could all do that while she's in your clinic. Kind of think through How many people could just do a pop-in safety plan that just covers the basics, where she walks out of your program having verbalized 2 or 3 times what she's going to do in its most basic form if all else fails? So let's look quickly at some boundaries in safety planning. We've talked a lot about respecting the person's choices. That's going to be really important. I'm not going to tell them this is what you have to do to be safe. And I'm going to tread a little lightly on this next one, and that is to accept the consequences of behavior. There is a difference between a safety plan and a get-out-of-jail-free card, right? So if I'm sitting with someone and I'm helping them make a plan to lie to their parole officer or to do something illegal or to deceive the Department of Children's Services, that should create pause, right? I cannot create a plan that protects everyone from all the consequences of their behavior, and it would probably be unhealthy for me to do so. So to really think through, what are those boundaries for me? Am I actually encouraging someone, am I helping someone make a plan that violates the mission of our agency or my own personal, standards? So we want to avoid vilifying others. We talked some about that. It's going to be really tempting to say, of course, we wouldn't even have to do this if your husband wasn't like this. Of course, we don't want to build frustration there and blame others. And these next 3 things we really have to remember just when we do this kind of work. One is that you're probably not the solution, right? If every safety plan ends with, oh, of course, sweetie, you can always call me. Here's my cell phone number. Call me anytime. Unless that's in your job description, that's probably not sustainable and it's not healthy. You are probably not the solution. It's so discouraging to sit and talk to someone and realize, wow, she really doesn't have anyone to call. And it's very tempting to say, all right, I shouldn't do this, but here's my number. And we've got to set some boundaries there. We're not going to be able to be everyone's safety net for that. Making promises you cannot keep. Sweetie, you can always come back here. No matter what, you can always call me. Well, is that true? Where will you be in 18 months? Do you know for sure you'll be there? Is she going to be eligible to receive services at your program literally no matter what? So that's important to think through and to not just throw out phrases like that and then have a client call you in 6 months and have to say, oh, yeah, actually that's not true. So think through, what are the things that we can do and the things that we can't do, we're not equipped to do. And then I have to be okay even if you're not. That's going to be essential in doing this kind of work. So if we get to the bottom of the safety plan and I just realize, man, I'm not sure she's going to be all right. I'm not sure I have to be okay anyway, right? I can't allow my own sense of well-being, my own sense of peace, my own ability to be happy, my own ability to sleep and to eat, be dependent upon the well-being of my clients. It is very possible and healthy to have compassion for someone and to care deeply about someone, and also to be okay if they're not. So just sort of a checklist of our own mental health kind of things to keep in mind when we're really getting down into the weeds of, is this person going to be okay? Is this client going to be safe? And what we're going to do and how we're going to handle it when the answer may be no. I'm not sure that they are, and I'm not sure I can do anything to guarantee that. But I still know who I am and what I can offer, and I'm still going to be okay. And of course, we keep in mind that the women we work with, oh my goodness, are extremely resilient and extremely creative. And we listen to the stories of what they've been through, and we should realize these women are fighters. These women, they don't quit, and they figure out what to do. And we can let a client's, oh my goodness, just terrible story inform that mindset. You clearly know a lot of what you're doing here. And so having trust, a little bit of trust in our clients as well. So probably the most awesome thing about a safety plan, and probably the biggest advantage to a safety plan, is that it communicates care and concern for the women that we're serving. A safety plan says, you know what? We got a lot going on here. We've got all kinds of services and all kinds of people. I'm going to take a few minutes here, and I'm going to look right at you, and we're going to figure out everything we can do to keep you safe. That communicates care. It communicates value. You're important to me. So, so I want to talk about how to keep you safe. You may be the only one who communicates that to that client. You may be the primary person who gives that message. And so even if everything she said is a lie, even if the whole plan is based on farce, what you have done is you've said that. You are valuable. You are important. We want to keep you going. We want to keep you healthy. So let's talk about what it looks like to do that. And there may just be one person in your whole program who does that. But everyone in the agency can find reassurance in knowing that it's done. I may never safety plan with a client. I may be the one who checks them in as they walk in the door, and I never get to have that conversation. I never get to look at them and say, hey, I care about you. Hey, we're concerned about you. But if I know that a safety plan is a part of the process, then I can rest assured that someone is doing that they walk out the back door and someone has created that time and space and said, we all care about you. And so it provides, again, some of that peace of mind, some of that special magic stone element that we talked about at the beginning for everyone who works in your program. All right, so we have time for some questions and answers. And Caroline, I'm going to let you direct those my way. Anything like that we need to address?
Great. Thank you so much for your presentation, Cindy. As Cindy mentioned, we will now begin the Q&A portion of the webinar. If you haven't already done so and you would like to, please feel free to enter any questions you might have for Cindy into the chat box. As a quick reminder, the CME claim code is now available and will only be available during this session, so please do make note of the code if you plan to claim CMEs. Okay, our first question is, what would you suggest towards an effective safety plan for homeless women with mental health concerns such as bipolar disorder?
Absolutely, and that can be, wow, that can be really tricky. And that's where when we talk about, what is the person's ability, what capacity does this woman have even to think about her own safety? And when we think about bipolar disorder, of course, risk-taking is so much an element of that. So a big part of her safety plan and of the safety plan of someone dealing with mental health issues is going to be around that mental illness. And so one really important element to include can be, all right, what does it look like when you're approaching a mental health crisis? So we know that you're going to have times where you take unnecessary risks, where you don't sleep, where maybe you don't eat, whatever all those manic or even perhaps severely depressive behavior symptoms look like in your client. Are there signs that those are coming? Are there people around you who can say to you, hey, I'm a little worried about you. You seem like you're getting really depressed, or you seem like you're getting really worked up. And so that can be a big part of that safety plan. Again, knowing the medications, knowing the diagnosis, and knowing safe, trusted providers is also going to be a big part of that safety plan. Ideally, again, building that support system. And even if the support system is just providers, is just agencies, still, people who are regularly checking in with her and that she can say, hey, I feel like something's a little off. So I would even role play that conversation. Okay, let's say that you realize, hey, I didn't sleep last night, or I'm just feeling kind of down. Who could you talk to about that? What steps could you take? And really think about, let's not ignore those symptoms. And then ideally surrounding yourself with people who can also help you navigate and sort of observe those changes.
Great, thank you so much. Our next question is, how can we make a safety plan with hopeless women? Can you give an example?
Yes. So when you look at a woman who is completely lost hope, what you're really going to be doing there on some level is a suicide assessment. So when you say you've lost hope, I hear you say that nothing's working and that, however she expressed that you pick up on, okay, she's feeling hopeless. You would immediately want to assess for suicidality. And that means really clearly asking the question. So you sound kind of hopeless to me. Are you feeling like killing yourself? Do you feel like killing yourself? And then her answer, where does that fall on the overall spectrum of suicidality? There's a difference between someone who doesn't want to wake up in the morning and someone who has, purchased a rope and has set a date and knows exactly where she's going to hang it. That's that there's a huge difference between those two. So that's where you would really want to, as a program, think about, okay, let's just flat out ask, are you feeling like killing yourself? And if not, then what are things that make you feel hopeful? Let's try to insert in our safety plan elements of hope. Okay, are there things in her story that you're aware of, things that she enjoys, times when she felt encouraged, things that she's good at? Some people feel hopeless and are very easily encouraged. Some people feel hopeless and they can have one really upbeat conversation and feel significantly better. So where in the great spectrum of hopelessness is she? Is she suicidal, or is she just really discouraged? If she's really discouraged, what can she do? What does she put in place in her life to help her feel encouraged? And if she's suicidal, then as an agency, what is your policy for that?
Great, thank you so much. Our next question is, can this apply easily to men as well as LGBTQ folks?
Yes, I think so. I think pretty much everything I've said would be applicable to anyone regardless of gender. Our focus right now is women's health, and so we really talked about this from a female perspective, but I don't know that there's anything I've said that wouldn't apply across the board.
Great, thank you. And our next question is, we got a question from someone who says they work with clients who are homeless due to leaving their abusers. Because of a general lack of housing in the state, they feel that going back to the abuse is their only option. Are there any federal funds dedicated to housing for domestic violence or intimate partner violence victims who need housing?
That's an excellent question. It's a little bit beyond my scope of expertise. I will absolutely agree with the first half of that, and that is, the average woman in a domestic violence situation will return to her abuser 7 times. And so that is going to be a regular part of working with women who are leaving domestic violence. Caroline, you might know more about that than I do, but that is a little, as far as what specific federal funding is available, that's a little bit beyond my level of expertise. I will say that just thinking outside of the box and what can we do to help get her to a safe place? Is there someone in another part of the country? Is there a church? Is there any sort of community group like that she's partnered with people that are abusers unfamiliar with? All of that sort of out-of-the-box thinking that we do with women who are looking for someplace else to go. But specifically about federal funding, I would not be familiar with. Sorry about that.
Great. And yes, we do have resources here at the Council, too, to look into that a little bit more deeply, so we would be happy to follow up with anybody who might be interested in that. And it looks like we have time for about one more question. Many of you submitted questions. Thank you so much. As we mentioned at the top of the webinar, we will document all of the questions that have been submitted and create a document full of written responses to post with the archived recording next week. So if we weren't able to get to your question today, don't worry. We will submit a response to it when we post the recording next week. So one more question, and that is, are there any tips on providers' safety planning with clients in rapid rehousing programs? Should safety plans be in their files?
Yeah, that's an excellent question. Most of the rapid rehousing programs that I work with offer as part of their program, and this may be required, sort of that permanent support or permanent case management, or to whatever degree the client wants to take advantage of that. And so, again, that may be someone who's meeting with a case manager regularly and can regularly have those conversations. But yeah, I would say absolutely. Whenever someone's transitioning from homelessness into housing, this is a time where we can tend to think, woohoo, there's no more issues, everybody's safe now, everybody's good, and we never have to think about safety again. For some clients, that's when they're most vulnerable, is when they make that transition from homelessness to housing, because their whole lifestyle changes, right? Everything that they used to take comfort in is gone. A lot of times their support system is gone. Their community is gone. There's a strong sense of community, as we all know, among people who are homeless, who are living together. And when I'm housed, suddenly I lose all of that. And so there can be all kinds of just culture shifts that are really disorienting and really and can actually be depressing for people when they move from homelessness into housing. So that would be an excellent time to think about incorporating a safety plan, because for a lot of those clients, boy, they're moving into unknown territory, and especially financial safety planning and who do I have in the house there with me, and just practical things that those of us who've been housed our whole lives never think about.
anytime you've got a client going through a major transition, even when it's a super good transition, that's going to be an important time to safety plan and to keep checking back in and see what things have come up that are scary for the client. It may be a totally different kind of scary. It's one kind of scary to lay in your tent and wonder if you're going to be attacked. It's another kind of scary to lay in your bed and wonder if you're going to have the money to pay all your bills. So that's a whole different kind of scary. So absolutely, yes. Anytime there's a big transition, that's going to be a good time for safety planning.
All right. Thanks so much, Cindy, for your presentation today. It sounds like we might have lost audio right there at the end. Sorry about those technical troubles again. What we will do is go ahead and post the response to that last question, again with the other responses that we post next week. So don't worry, we'll make sure to capture everything that was asked today. Thank you so much for attending today's webinar. We really appreciate your being with us today. A link of the archived recording as well as all of the presentation materials will be posted to our website next week. Please do copy and follow the instructions to claim your CME credits for this session. The instructions are there in the CME instructions pod. Again, the claim code is only available right now, so please do make note of that, and credit must be claimed within 3 days. An evaluation of today's presentation should automatically appear in your browser at the close of this webinar. If it does not, please do copy and paste the link that will be on the closing page right when the webinar closes. We really appreciate your time and your feedback, and thank you again for attending today.